for success of or successful outcome of vitiligo surgery is selecting a proper patient. So apart from this 1 year stability period, which is defined by no expansion of existing lesions and no appearance of new lesions, no absence of Koebner phenomena for past 1 year. But if there is a doubt, it is always good to take pictures and then take pictures again and at 6 months apart and compare, or compare with the pictures which are already there with the patient, and to see and define the stability in any given patient. Then examination of depigmentation pattern and borders is very important, and I call it them pseudopods. Inward pseudopods of pigmentation is a good sign. Outward pseudopods of hypopigmentation or depigmentation is not a favorable sign. So this is a good sign. The patient is getting pigmentation coming inside from the border. That's a good sign. And ill-defined border, indistinct border, expanding border, hypopigmented border, not a good candidate for vitiligo surgery. And if there is a doubt, there is another good simple thing, that is test punch grafting, in which 3, 4, 5 punches are grafted on the recipient vitiligo patch, and then we observe them in next 3 to 4 months to see if there is peri-graft spread of pigmentation. So here in this case, you can see I am holding patient's own smartphone and comparing with the outcome. You can see that majority of the punches have lost the pigmentation. So even though this patient was a stable vitiligo, was not a suitable case for transplantation. So another aspect is, this is a multicentric study by Dr. Venkatram Mysore and colleagues and Dr. Imran Majid. So lesional stability versus global stability. Is it possible that one lesion is stable, but other lesions are active? And if we can do a transplantation in one lesion to have a successful outcome? So there is a possibility. However, I feel that there may be many more studies which are needed before we reach to any conclusion. So for example, in this patient, we did test grafting in a patch on hand and patch on eyelid. So on the eyelid, she got peri-graft spread of pigment in 3 of the 5 grafts, and majority of the grafts on the hand lesion, they got depigmented. So there is a possibility that one particular patch is transplanted and other patch is not transplanted because of the differential stability or activity. So how to improve the outcome of vitiligo surgery? One simple principle is a smaller unit graft and thinner tissue graft have advantage in vitiligo surgery. Dermal component in harvested recipient tissue is unnecessary, not only unnecessary, but detrimental to the final outcome. I will tell you how in next few slides. So over the years, thin split thickness graft has given way to ultra thin graft, suction blister graft, smash graft, and Jodhpur technique. Punch graft replaced with mini punch graft, which is now being replaced with micro punch graft. Tissue grafts are being replaced with cellular grafts. So you can see that single most common factor in these 3 lines is the graft unit is becoming thinner or smaller. So this is a picture courtesy from Dr. Kaushik. You can see that punch graft is showing peri-graft pigment, but the extent of pigment is not very great. So way back in 2007, what we did dermabrasion of recipient site and transplanted trypsinized epithelial flags, not cell suspension, but tiny flecks. So these hyperpigmented spots in the center are actually the tiny flecks applied. And you can see the peri-graft pigmentation spread the extent because the graft unit was smaller. And eventually, the whole area got repigmented. So this is the beauty of a smaller unit graft. And because that provides melanocytes to capability to repopulate quickly in the whole area. Now, this is a thin split thickness graft, not acceptable. This is ultra thin skin graft, which is better taken by motorized dermatome. And even better are suction blister graft, because there it is physiological split and no texture abnormality because epidermis adopts to the recipient site. And here again, split thickness graft, somebody did not needed. If you do cell suspension transplantation, there is no texture abnormality, and even the hyperpigmentation improves with time, pigment mismatch. Punch graft, not acceptable, cobblestoning. Mini punch graft, 1.2 mm, hardly any cobblestoning. Now, Dr. Jung has introduced the concept of motorized 0.8 mm micro punch graft using hair follicle punches, but and even smaller. Now he recommends 0.5 mm. So these tiny patches are taken with the motorized punches, which are used in hair transplantation, hair extraction. And here, because the graft unit is so small, that the aesthetic outcome is excellent. Another patient of the same. And here you need not to bother epidermal side up or dermal side up. Just put them because grafts are so small, it doesn't matter whether epidermal side or up or dermal side up. So this is the paper thin graft, which we have shown here. We have taken for epidermal cell suspension preparation. So if we take a thin graft on the recipient donor side, there is no scarring. And from the same site, we can take graft for future sessions because graft is so thin. And when the graft is so thin, the cell suspension preparation is much easier. So dermis is detrimental in vitiligo surgery. We need not to take. It causes donor site scarring, and on the recipient site also, it causes mismatch in pigmentation and texture. So how to take thin graft? We have to practice, practice, and practice. And we can do practice on models or on tomatoes, but it has to be a very thin graft so that there is no immediate bleeding. One simple tip is an assistant should stretch the skin in two directions, one downward and lateral, so that we can get a very thin graft. And once we have taken the very thin graft, then the job is easier. Now, coming to suction blister, this is the suction syringe which was introduced by us long back, 2 decades ago, and it was published in the Journal of the American Academy of Dermatology. But everything comes with an expiry date. I am happy that a newer pearl is better than original pearl which was proposed by us, and this is this hijama cups. And hijama cups, they provide better suction blisters, and they are available in different sizes and faster suction blister. More often we get the unilocular blister. However, if the blister is small, we can simply inject saline in the inside the blister cavity by entering from the adjacent area to increase the blister surface area to graft in a larger area, like in this. And we studied and we found that we could increase the pre-injection mean blister area from 131.9 millimeter square to 186.6 millimeter square. So which was statistically significant. So we can increase the area of blisters. Then again, on the recipient side, the transplantation, the dermabrasion has to be very, very superficial, because we have to transplant at the basal layer of the epidermis. If we do a deeper dermabrasion, there is delayed healing, chances of pigment failure are greater, and chances of scarring are also greater. So you can see that how superficial dermabrasion I'm doing in this video. It is a very small, like just tiny pinpoint bleeding, which is the end point. And always we have to dermabrate 1 to 2 millimeter beyond the vitiligo patch, because otherwise there is a greater chances, there are greater chances of perigraft achromic fissure or the achromic halo. And always good to mark all around so that we know the extent of dermabrasion where we have to do it. So this is a simple tip. And always have a good diamond burr, because if diamond burr is not good, we end up putting a lot of pressure and a lot of trauma on the recipient side. So that's a good investment to have a diamond burr every time, a new diamond burr for a new patient. So, but this is dermabrasion is a difficult, tricky technique. These are all dermabrader machines in our department, and none of them is working. It is the most fragile equipment in our department. So we always, and apart from that, it creates aerosol in the operating room, which is and contaminates everything. So we always try to find a way, simple way, which is not dermabrasion to prepare the recipient site. So this is one of the simple pearl about recipient site preparation. You know that this paint, lactic acid and salicylic acid paint for wart treatment, the if we apply 2 or 3 times in the preceding week on the vitiligo patch, it causes the exfoliation of the skin, which can be removed by simple gauze. Rolling a gauze in the finger and abrading the area removes the epidermal layers, and it doesn't go deeper because exfoliation takes place only in the epidermis. So this is an alternative to dermabrasion. Another equipment which is needed is incubator, but these incubators are large, expensive. Why should we have it in our OT and unnecessarily occupying space, because it is not used in any other procedure. So when I went to Africa, South Africa for a workshop, they provided me this egg incubator to incubate the sample. I liked it and it worked very well. So apart from that, we can use patient's own heat to incubate. So nowadays we are putting the sample in patient's own axilla, and axilla has the 37 degrees Celsius temperature, and in 35 to 40 minutes, the trypsinization process is over. Incomplete repigmentation, even after transplantation, all patients may not get complete repigmentation. Some area may be left behind. So what we found, I coined the term peri-procedure immunosuppression or immunomodulation. If we start few weeks prior to surgery, cyclosporin or tofacitinib or another immunomodulator drug, and continue after procedure for few months, we have found that the transplantation outcome is much better. Apart from that, this Dr. Kachawa's technique. So together with Dr. Kachawa, we published this simple pearl for achromic fissure all around after transplantation. So here what he did is he took the brushings of the surrounding skin by manual dermabrader, put some antibiotic ointment and dermabraded the surrounding skin and sprayed those brushings on the dermabraded achromic fissure. So he combined the donor area and recipient area, and there was a complete repigmentation. Apart from that, we can use Excimer, or we can use handheld narrowband UVB home unit, or we can use even hospital-based phototherapy to complete the repigmentation after transplantation. Or we also reported that if we resuspend the pellet in platelet-rich plasma, then the outcome is slightly better than when it is resuspended using ringer lactate. So this is another simple tip. Okay, in the interest of time, I will just focus on one more important aspect, leukotrichia. So while leukotrichia reverses in some of the patients after transplantation, but in majority of the patients, it doesn't. So we systematically studied, followed these patients for 9 months, and what we found is that while epidermal repigmentation is very good, these green bars, but leukotrichia repigmentation was seen only in the mean 20% of all hairs after 9 months of follow-up. So leukotrichia repigmentation doesn't occur always with any transplantation method. So a simple procedure for this is doing FUE, removing the white hair and transplanting pigmented hair either from the contralateral eyebrow or from the scalp. So to complete the improvement. And sometimes even for vitiligo patch, we can do FUE transplantation, remove the white hairs and in the same socket, replace them with the scalp pigmented hairs from the scalp. And hair follicle can also be a source of melanocyte and stem cells. And it is equally good as epidermal cell suspension. And sometimes we can use plugged hair follicle, because if we extract the hair follicle is lost completely. But when we use plugged hair follicle, the hair regrow. However, plugged hair follicle is not a very good source of cells. So when we are using non-cultured cells, But when we are using cultured cells, we found that epidermal cell suspension, extracted hair cell suspension, and plugged hair cell suspension, all three provided similar results, no difference. So because in culture, we expand in the laboratory for 3 to 4 weeks to grow the melanocytes in the culture. However, it's a tedious process. Last but not the least, depigmentation. These two are sisters. One is having normal color and the other is having universal vitiligo facilitated by depigmentation using monobenzyl ether of hydroquinone. So, if there is a uniform color, no matter whether it's a normal pigment or it's a depigmented uniform color, both are considered equally beautiful. So this is underutilized treatment, particularly when there is extensive vitiligo, then we can use a depigmentation therapy. And this is our book, international book, Henry Lim, with Dr. Henry Lim, Devendra Prasad, Dr. Nanya Von Giel, and Dr. Amit Pandya. Dr. Henry Lim is currently ILDS president. So I thank again IADBL West Bengal for giving me this opportunity. And sorry if I overshooted the time.
Thank you, Dr. Sumesh, for a wonderful talk. And we learned a lot and many pearls from your vitiligo surgery experience. So I think audience must have gained a lot through this lecture. Now I invite Dr. Anupam Das, who will be talking about recent updates in management of vitiligo. Dr. Anupam, please stick to the time.
Thank you, sir. My slides are visible, na?
Yes, it's visible.
Yeah. Okay. Thank you for the kind invite to speak on recent updates in the management of vitiligo. Now, after Somesh sir sharing his own experience, his immense experience in surgical management of vitiligo, it is very difficult for me to match the standard while presenting on recent updates. I'll try to do my best. Now, starting with the basics, vitiligo, we all know it has been a very elusive disease, and the pathomechanism behind the development of the vitiliginous lesions has always been an enigma. So, different hypotheses have been proposed regarding the pathomechanism of vitiligo. You have the neural hypothesis, you have the chemical hypothesis, you have the neuroendocrine hypothesis. Then you have autoimmune hypothesis, which is one of the most widely accepted ones. Apart from that, you also have the oxidative stress theory, which is ruling the roost as of now. And vitiligo, we all know it has been associated with several autoimmune diseases, starting from your Hashimoto's thyroiditis, type 1 diabetes mellitus, pernicious anemia, rheumatoid arthritis, and various entities. So this is in very brief regarding the pathomechanism of vitiligo. As you can see, a lot of complicated things are going on in the epidermis as well as the dermis. So if we think of oxidative stress, what happens is, as a result of the oxidative stress, there is release of certain chemicals, certain PAMP and DAMP molecules, which activate the keratinocyte, as a result of which there is liberation of reactive oxygen species. Now, these reactive oxygen species, they are responsible for triggering the release of plenty of cytokines and chemokines, most important ones being interleukin 15, chemokines CXCL9, 10, 16. The end result being there is elevation of certain pro-inflammatory cytokines, starting from interferon gamma and various other cytokines. And at the end, what happens is there is melanocyte destruction. There is apoptosis of the melanocytes. Apart from that, the senescence of melanocyte is heralded. So this is in very brief what happens in the epidermis and the dermis in vitiligo. So whenever we think of managing vitiligo, we have two basic objectives. First is we have to arrest the progression of the disease, for which we need to give, say, steroids. We need to give steroid-sparing immunosuppressives. Apart from that, we have small molecules, we have MABs, monoclonal antibodies, lots of molecules. Apart from that, we have to induce pigmentation in the already depigmented lesion. So these are the two basic aims of therapy. And the treatment, there are different treatment algorithms, different protocols, but I suppose all of us tailor the treatment according to the needs of the patient, according to the comorbidities of the patient, also according to the affordability of the patient. So various factors which are taken into consideration while treating vitiligo is whether the disease is stable or not, whether there is any progression or not. We have to halt the disease. What is the body surface area involvement, whether it's less than 10, 10 to 40 or more than 40? What is the type of disease? What is the site of involvement? Whether there are any comorbid conditions or not. So these are the different treatment modalities. Surgical therapies I'm not going to touch upon. We have topical therapies, we have phototherapy, systemic therapies, and experimental therapies, of course. Now, something which has garnered a lot of attention over the last few months, I would say, are JAK inhibitors. So this is the entire platter of JAK inhibitors which are available in India and outside India, starting from ruxolitinib to delgocitinib. Tofacitinib is, of course, which is being used left and right by all of us. Apart from that, you have baricitinib, padacitinib, and ritlecitinib. So how do JAK inhibitors act? We all know there is phosphorylation of the JAK moiety, as a result of which there is induction of the STAT molecules. There is combination of the JAK and the STAT. The two JAK and the two STATs, they conglomerate, and that particular complex moves inside the nucleus, leading to transcription of certain proteins. So transcription of mRNA, which leads to translation of certain proteins. So what JAK inhibitors do is they block this binding of the JAK and STAT molecules, and they also block the movement of the JAK STAT compound molecule inside the nucleus. Now, oral JAK inhibitors, they do work in vitiligo. We all know the mechanism of action, but there has been a lot of debate whether topical JAKs work or not. Just I would tell you that there are plenty of cytokines which have gained attention in vitiligo. Most important ones being interferon gamma and certain chemokines, your CXCL9 and 10 and interleukin 15. Now, interleukin 15 levels are found to be very much increased in the vitiligo lesions, and that is responsible for maintenance of the resident memory T cells and stimulation of interferon gamma and those pro-apoptotic cytokines like your granzyme B and perforin. So what happens is, since these responses are mostly focused on the epidermal layer, that's why topical JAK inhibitors are expected to be effective. Now, topical tofacitinib, so far as data is concerned, we do not have much data from our part of the country. This was one of our reports where 11-year-old otherwise healthy boy had presented with vitiligo over the face. He was previously prescribed topical mometasone, tacrolimus, everything, but there was not significant improvement. So we prescribed topical tofacitinib 2% gel twice daily over the lesions. Now, this was prescribed at a time when tofacitinib ointment was not available in our part of the country. So this tofacitinib 2% gel showed a dramatic response over a period of 4 weeks. The child is still under periodic follow-up, and there is no relapse or any serious adverse event. Now, this was way back in British Journal of Dermatology 2020, where an open label pilot study was conducted with 2% tofacitinib ointment for the treatment of refractory vitiligo. 16 patients were recruited, and as you can see, 4 patients experienced more than 90% repigmentation, 5 experienced 25 to 75% repigmentation, and it was concluded that topical tofacitinib ointment is safe and efficacious. Now, if you observe very carefully, most of the patients, there was a concomitant phototherapy administered. So we can probably conclude that topical tofacitinib will work better in those patients who have lesions on the sun-exposed areas, say in the head neck region, in the facial region, and where you can go for phototherapy, even if not phototherapy, considering the amount of sunlight we are exposed to, routine sunlight exposure can also help in achieving repigmentation. Now, this was another study published in JAD, where again topical tofacitinib cream with narrow band UVB was utilized for facial vitiligo. You can see a change in VASI, the improvement in the quality of life was statistically significant over a period of 4 months. This was another isolated report of use of topical tofa in an adolescent patient, where again concomitant phototherapy was given. You can see significant repigmentation has been achieved in the eyelid region, in the forehead, also in the lip, nose, and perioral region. Again, topical tofacitinib along with narrowband UVB has shown good results in segmental vitiligo in children. Almost complete repigmentation was achieved after 6 months of therapy. Now, this is interesting where repigmentation of vitiligo-associated eyelash leukotrichia was also achieved with the help of topical tofacitinib cream. At the end of 5 months, almost complete repigmentation was achieved. So this was a good systematic review where authors mentioned that topical JAKs are almost equally efficacious to topical corticosteroids in the treatment of vitiligo, and they are more effective than topical calcineurin inhibitors in treating vitiligo. Coming to oral JAK inhibitors, now how they act, we all know it is absorbed systemically and it traverses to the melanocytes. And what it does, it inhibits those JAK-STAT phosphorylation, dimerization, and movement of that particular complex inside the cell. And coming to the evidence of use of oral JAKs in vitiligo, different case reports are there from different parts of the world, and you can see that almost 5 to 10 milligram twice daily is one of the most widely accepted doses when it comes to prescribing oral tofacitinib in vitiligo. Ruxolitinib we don't have, so I'm not going into that. In most of the cases, as you can see, significant repigmentation has been achieved at the end of around 4 to 6 months of therapy. Yes, we should not be very much careless while prescribing oral tofacitinib because it has its own set of side effects. We need to be very careful regarding the baseline investigations. In a country like ours, we need to be careful about latent tuberculosis infection. We need to be careful about reactivation of herpes zoster. There can be a transient rise in the lipid levels. There can be upper respiratory tract infections. There can be nasopharyngitis. We need to be careful about that, and routine follow-up and periodic laboratory investigations should be done. In pediatric vitiligo, yes, reports are scanty, but yes, oral tofacitinib does work in pediatric vitiligo, provided we are using that in combination with the narrow band UVB. This I've already mentioned. Mild elevations of lipid levels have been reported in most of the studies where oral tofacitinib was prescribed. There can be recurrent headache, recurrent flu-like symptoms, but these things usually resolve with discontinuation of therapy. These are certain newer JAK inhibitors which are not yet available. These are under trials. One of them is ifedancetinib, which is a dual JAK1/3 inhibitor undergoing phase 2 clinical trials. JAK3 inhibitor, this is very specific, ritlecitinib, and this is probably going to be the most specific JAK inhibitor if available. Because the problem with using JAK inhibitors is we do not have a selective molecule because it will target JAK1, 2, 3, tyrosine kinase to everything, as a result of which there will be collateral damage and a lot of side effects. So ritlecitinib is something which is going to be very specific and chances of side effects are going to be very less. Apart from that, we also have brepocitinib, which is JAK1 and TYK2 inhibitor. All of them are undergoing evaluation in active non-segmental vitiligo. Apart from that, topical serudulatinib gel is also undergoing evaluation, which is a dual kinase inhibitor. Coming to some other molecules which are under trial, and these are very theoretical. One is your WNT signaling and associated agonists. Now, it has been shown that this WNT beta-catenin signaling plays a very significant role in the proliferation and differentiation of melanocytes in vitiligo patients. And since oxidative stress has a very important role to play in pathomechanism of vitiligo, it has been shown in vitro that intradermal injection of IWR1, that is inhibitor of WNT response 1, suppresses the number of epidermal melanocytes. And this evidence suggests that stimulation of WNT signaling in future may be an adjuvant therapy for vitiligo treatment. MicroRNAs are something which are being discussed in almost all the dermatological conditions right now, starting from your psoriasis, alopecia areata, lichen planus, vitiligo, everything. Now, microRNAs, these are basically a highly conservative class of non-coding RNA molecules, and they participate in the expression of mRNA. So these microRNAs do not directly contribute towards translation of proteins, but they regulate the transcription and translation of proteins. Now, previous studies have demonstrated that microRNAs are associated with a lot of genetic polymorphisms, oxidative stress, melanocyte functions, and this is responsible for pathological mechanism of vitiligo. So probably modulating the function of these microRNAs can help in arresting the progression of the disease. Treg cells, T regulatory cells, these are also gaining a lot of importance now. These cells are basically suppressive CD4 T cells, which have the capacity to suppress T cell activation and expansion. So what happens is in vitiligo lesions, in the lesional skin, in the non-lesional skin, peri-lesional skin, what happens is there has been, authors have observed that there is a clear decrease in the levels of Treg cells. So probably, this is very theoretical, probably infusion of purified population of Treg cells is one of the future promising modes of therapy while treating vitiligo. Interferon gamma and the inhibitors, this is again very theoretical because in active vitiligo it has been shown that there is a higher expression of interferon gamma mRNA. So probably blocking those interferon gamma with the help of interferon gamma neutralizing antibodies may lead to significant depigmentation. In mouse models, these have been found to be effective. In human model, we do not have data. CXCL10, as I mentioned, CXCL9, CXCL10, all these are very important chemokines involved in the pathomechanism of vitiligo. So probably if we develop antibodies which can neutralize these chemokines, it can be a good therapeutic strategy in future. Heat shock proteins, again, this has garnered a lot of importance in many dermatological conditions, non-dermatological conditions also, starting from malignancies to everything. So recent studies have demonstrated that there is an increased expression of heat shock protein 70 mRNA in the skin lesions of active vitiligo patients. So probably this blockage of inducible heat shock proteins may have the potential to reverse vitiligo development in future. Interleukin 15, as I mentioned, anti-CD122 antibodies. This is again very theoretical, and all these things are under trial. And so far as data is concerned, adalimumab and infliximab are they do not have much good data when it comes to treating vitiligo. Interleukin 17 inhibitors, secukinumab and secukinumab, again, we do not have much good data. Abatacept is something which is under investigation. Anti-CD20 rituximab is something which has shown isolated good results in different studies when it comes to treating vitiligo. So just to summarize, if we think practically as of now, probably the most promising options are JAK inhibitors, but we need to be very careful while prescribing JAKs because they have their own set of side effects, and we live in a country where latent tuberculosis is pretty common, and we need to be very careful and vigilant while prescribing JAK inhibitors. There are instances of development of acute hepatic failure. There are instances of development of severe liver injury, acute pyelonephritis, UTI, severe infections while prescribing JAK inhibitors. We should not prescribe unless it is seriously indicated, absolutely indicated, the baseline investigations are proper, and the patient really needs JAK inhibitors and he's not responding to the conventional steroids or steroid-sparing immunosuppressives. Apart from that, if we are thinking very theoretical and if we are thinking very futuristic, maybe many years down the line, microRNA-based therapeutics and adoptive T regulator cell therapy are the facets where the future lies while treating vitiligo. Thank you everyone for your patient hearing.
Yeah, thank you, Dr. Anupam, for your illuminating talk. Now I would invite Dr. Abhijit Shah to speak on childhood vitiligo and its nuances. Dr. Abhijit, please.
There is some technical problem in my video, so I can't be visible. Inconvenience regretted. So for next 15 minutes or so, I'll be speaking on pediatric vitiligo and how does management differs from its adult counterpart. At the outset, I want to express my sincere gratitude to West Bengal IDVL for providing me this opportunity, and my special thanks to Dr. Sudeep Das sir for personally calling me and for this bestowment. So future is really bright. For last 2 to 3 decades, there has been a considerable improvement in the management of childhood vitiligo. To me, management of childhood vitiligo starts from proper diagnosis, exclusion of vitiligo mimickers, taking care of the psyche of the child as and when required for that matter, and obviously treatment with surgical and medical facilities. So without further ado, let's get the ball rolling. So vitiligo is one of the commonest reasons for dermatology consultation in pediatric age group, and it needs to be differentiated from several congenital nevoid and hypopigmented disorders. Segmental vitiligo is a frequent occurrence, resistant to medical therapy, amenable to surgical therapies. But there is a good news I'll be sharing in the latter part of my presentation regarding the medical therapy of segmental vitiligo. So as we all know, childhood vitiligo mostly occur over the head, neck, and face region, over the periocular, perinasal, and perioral areas. And mean age of onset is around 5 to 7 or 8 years of age, but it may occur even in infant and neonates, and may even start around the perianal area, just like this. Even congenital vitiligo has also been reported. This is another case of infantile vitiligo. Suddenly depigmented patches developed all over the body following an episode of viral fever. Straightforward diagnosis, actual vitiligo, but sometimes you may confuse it with this kind of presentation. Now, if we look at the pattern, these depigmented patches are there over the central forehead, anterior part of the anterior surface of the body, mid portion of the extremities, along with number of hyperpigmented macules scattered here and there within this depigmented patch. That means we are dealing with a case of pyvaldism, and in most of the cases, in more than 85 to 90% of cases, pyvaldism is associated with white forelock. Now, two similar pictures, but left one is of vitiligo with leukotrichia, and the right one is of Waardenburg syndrome with white forelock, depigmented central forehead macule, heterochromia of the iris, and sensorineural hearing deafness. Again, to similar picture, but left one is representative of segmental vitiligo with some repigmentation here and there, and the right one is representative of segmental nevus depigmentosus with serrated margin. Now, sometimes this kind of presentation may confuse you with partially treated vitiligo, but as soon as you look at the genitalia, your diagnosis is 100% confirmed. It's a simple case of seborrheic dermatitis that readily managed, can be readily managed with simple moisturization. So now let's look at the psyche of the child. If we discuss the facts and figures, 50% of vitiligo patients develop vitiligo for the first time below the 20 years of age, and 25% of them develop first vitiliginous patch below 10 years of age. So actually, these are the years, these are the formative years of their life, and these are the years for development of their sense of self. So for such a long year, they have to bear with this cosmetically disfiguring, psychologically devastating, and socially stigmatizing disorder. And this picture actually depicts the influence of vitiligo on the psyche of the child. Rightly, it may lead to peer teasing, low self-esteem, poor body image, depression, anxiety, so on and so forth. So they need hand-holding, rapport building, and sometimes professional help as and when required. This is a wonderful article I found on net. This is an online search, online review that has been conducted among the practitioners in different countries across the world, and it was they concluded that practitioners are least comfortable treating infants, and 94.5% of the practitioners they are actually experiencing frustrations either continuously or sometimes while tackling these pediatric vitiligo cases. So this is quite interesting. Now, whether a child should be evaluated for other autoimmune diseases or not, whether to do or not to do this routine autoimmune screening is a matter of debate. The world is divided. The initial evidences are against of its routine use, but later on, there has been number of evidences. Those are actually supporting the routine use of this autoimmune screening, especially for thyroid dysfunction and vitamin D level. Now, coming to the treatment purpose, there is a lack of clear-cut consensus for the management of childhood vitiligo, as treatment has to be tailored according to the each patient's need. Now, these are the current options we have, and this is a quite usable and user-friendly algorithm you can use in your day-to-day practice. Now, coming to topical therapy, mid-potent topical steroid is a cornerstone or first line of the therapy. Obviously, you can use high-potent steroid, especially over the bony prominences like elbow, knee, and anterior shin. Topical calcineurin inhibitors like tacrolimus and pimecrolimus are the prime steroid-sparing agents, especially for the sensitive areas like face, neck, or eyelids, which are prone to topical steroid side effects. They can safely be used for children over 2 years of age. Sometimes they may irritate the skin, but those irritation usually goes off on its own, or we can mitigate it by simply refrigerating the tacrolimus ointment tube in simply refrigerating the tube only. Now, topical calcipotriol might not be very effective when used as monotherapy. And talk of the town, JAK-STAT inhibitor, they specifically inhibit interferon gamma signaling and expression of CXCL10 in keratinocytes. The market is flooding with different brands of topical tofacitinib. We also have ruxolitinib, recently been approved by FDA into 2021 for use in pediatric vitiligo over 12 years of age, obviously for non-segmental vitiligo. There are many more in the pipeline, and they are most efficacious when used for facial lesion followed by sun exposure or UVB exposure, and especially in Fitzpatrick skin type 4 to 6. Now, these are a plethora of evidences supporting the use of topical JAK inhibitors, and even before ruxolitinib got the approval, the number of these evidences actually had made the way. So this is a very interesting one I was talking about, recently published in BJD in 2024. They actually experienced some encouraging result while using ruxolitinib for segmental vitiligo. Now, these are some of the responses. We also have decapeptide, bimatoprost. Now coming to the systemic therapy, obviously corticosteroids are the cornerstone of therapy for to halt the progression of the vitiligo. Now, there has always been concern regarding the side effects profile of corticosteroid, and this use of corticosteroid has been revolutionized by Dr. Pasricha with oral mini pulse therapy, and this is something which I mean Western world learned from us Indians, and almost all of the side effects can be taken care of by this oral mini pulse therapy except bone demineralization. Courtesy to Dr. Manas Chatterjee sir for this information. And I mean, now Dr. Imran Majid has taken up the concept of Dr. Pasricha, and he used methylprednisolone instead. It was seen that disease process was halted in 90% of patients, and 65% patients achieve good to excellent repigmentation. He further took up another study to see how much relapse is possible after the stoppage of oral mini pulse therapy, and it was seen that about 1/3 of patients showed a relapse within 1 year of stoppage of OMP. So we are in search of a good oral steroid sparing agent which we can be used for prolonged period with minimum or less side effects. So here comes the role of methotrexate, well time-tested molecule in several childhood dermatosis. And again, the net is flooding with number of evidences, but all these studies actually, these studies have been conducted in adult population only. There is hardly any studies solely dedicated to pediatric population. Methotrexate is well known for its stabilization property and also for repigmentation property. But anyway, we can extrapolate this finding to our pediatric population, and actually that is what we have been practicing since a few years. Now, the same observations we have for azathioprine, though I do not have any personal experience. Now, coming to the cyclosporine, cyclosporine is extremely well tolerated by our children, and this is a study where they included both adult and pediatric population, lowest age being 7 years, and they concluded, along with the immunomodulatory properties, cyclosporine could have some direct effect on melanogenesis. So it's also able to promote repigmentation. In the study, 61% showed good stabilization, and 81% of them showed good repigmentation also. And this is the recent consensus guideline where the panel recommended the use of vitiligo is one of the prime indication for cyclosporine use. Now, we also have mycophenolate, mofetil, apremilast, and oral JAK inhibitors, but I do not have any personal experience. Coming to phototherapy, there has been mention of phototherapy even for use in vitiligo even in ancient time, and after that, over the years, the development of phototherapy was quite fascinating. PUVA therapy, Soralen plus ultraviolet A therapy, has not been recommended for children below 12 years of age because of its side effects like nausea, vomiting, phototoxic reaction, theoretical risk of cutaneous malignancy, and interference with the lentil development. So we prefer narrowband UVB therapy. I'm not going into every tits and bits of narrowband UVB therapy. Some areas responds better, like face, trunk, arm, legs, and some areas repigment poorly, like lip, nipple, wrist, ankle, and genitalia. Again, response is much better when used as a combination therapy with either topical JAK inhibitors or topical tacrolimus. And these are the advantages of narrowband UVB therapy, more effective than PUVA, no Soralen-induced side effect, and no photoprotection is needed for eye after the procedure. So can be used safely in children. Now, there are certain, special points for pediatric use of narrowband ultraviolet therapy. See, entering into the UVB chamber is claustrophobic in for most of the children. So that problem can be circumvented by accompanying the parents or any caregivers along with the child with full protection with sunglass, sunscreen, and all these photoprotective clothes. And now in resource-poor countries, this facility of phototherapy is available mostly in the tertiary healthcare center. So it might not be easily accessible to every person from a remote area. And multiple hospital visits 2 to 3 times a week leads to absenteeism and loss of school days, and obviously loss of working days and financial constraint for the parents also. So this is one of my patients before phototherapy, and this is after 12 sitting and 25 sittings of phototherapy. Now, eczema laser is a wonderful modality we have been using for some period of time. It's a much more focused therapy for a localized vitiligo involving less than 10% body surface area without any collateral damage to the surrounding skin. Again, the effect is much better when used in combination with tacrolimus. See, even a small depigmented patch of vitiligo may cause severe psychological distress. So phototherapy is an answer to those cases also. Not only this combination of topical tacrolimus, increase the efficacy of narrowband therapy, and the repigmentation starts early, but also this combination also reduces the cumulative NB-UVB dose. That should also be kept in mind. It's a beneficial one. Cosmetic cover-up sometimes needed when the child is undergoing treatment, but with severe psychological distress when the child is no longer ready to take any treatment, or when all the treatments have failed. Bleaching is generally not advocated in children, but we saw some wonderful cases from Dr. Somesh Gupta sir. Now, I'm not a surgery person. Whenever I get some children to be operated, I usually refer them to my dermatosurgeon colleagues. There are a few basic facts about surgery in the children. So when to consider surgical therapy? When it is a case of stable vitiligo, segmental vitiligo, and vitiligo causing severe psychological distress. And basic principle is to transfer viable melanocytes from the normal pigmented skin or hair follicle to the vitiliginous area. And these are the options. So, choice of surgery should be individualized, and patient selection is of utmost importance. There are certain factors we need to keep in mind, such as age, obviously disease stability, location, type, size, and duration of the vitiligo, availability of the equipments, expertise and comfort of the surgeon for a particular modality of surgery for that matter, and obviously expectation of the patient and parents. That is a very important parameter. And we know what stability is all about, as Dr. Somesh Gupta sir already mentioned about the lesional stability that has been proposed by Dr. Falabella, or pioneering personality in this field. And where to avoid surgery if it is active unstable vitiligo, especially childhood vitiligo and patients with unrealistic expectation. Certain pearls, few pearls about the vitiligo surgery in children. Better not to perform in very young children, because those vitelliginous patch, they usually extend proportionally to the growth of the body, and most of the this surgical cases require post-operative immobility that is very difficult to achieve in young children. Older children are better to counsel, and they are much more cooperative. So I mean, these are few general skincare measures. So these are my references, my acknowledgement. So thank you very much for your patient hearing. Thank you.
Thank you, Dr. Abhijit, for simplifying such a complex topic and giving us many pearls. Now is the time to listen to Dr. Sudeep Das, who is Professor and Head of Department of Dermatology, National Medical College, Kolkata, and he'll be talking about management of unstable vitiligo. Dr. Sudeep, please.
Okay. Am I visible? Start the video now. Video.
Oh, you are visible, but you have to do slide share, I think.
I'll share. Share on, Nina.
No, the whole screen is visible.
Put it in the slideshow mode.
Maybe. Okay, is it visible now?
It's visible, but you have to do it in slideshow mode, actually. No, it is. It will be in the right lower end of your computer, I think.
Again, that.
No.
Just a minute. Visible.
It's visible, but no change till now. Slideshow mode is in the right lower end of your presentation screen. Look, there is a icon.
Share screen is option. Okay.
Fine.
Okay. So, sorry for the initially got delayed. Thank you. We're starting how I manage an unstable vitiligo. That is one of the very areas. And is there a stable vitiligo or is there a unstable vitiligo? That is another question. So with that, let us go to the next part. So this vitiligo has been from the Vedic ages. If you look at this article, it is called Switra, or the treatment in the Vedas. The disease Switra was reported in ancient literature, and then it was known as Sweta, and it was also reported in the Atharva Veda. So it is not a new disease. When Switra, Kilasa, these are the symptoms. References to these were always available in the Agni Purana, Garuda Purana, and Mahabharata. So this actually is the disease from the ages. Now, IAD, the concept of stability in vitiligo is multifaceted and no consensus has been reached. The IADVL tried, the task force defined stability as a patient reporting to a new lesions, no progression of the existing lesions, and absence of Koebner phenomenon for the last 1 year. So that was as per the guidelines. Now, these actually keep on changing. Now, stable vitiligo is the following criteria should be met. When no new lesion developing in the last 12 months, actually when we were the residents, these were the things which were taught. Lack of progression of the old lesions for the last 12 months, and progressive lesions and new lesions developing or old vitiligo progressing in the last 12 months. What is rapidly progressive? No international consensus exists, but abrupt deterioration in the development of the new lesion or increase in size of the old lesions. Regressive, spontaneous repigmentation of existing vitiliginous lesions. So these were the global consensus. I think Dr. Shomesh has already, as Dr. Abhijit was telling, we've already discussed this VIDA score and all these things. The history of progression means absence of new lesions. That should be the most important criterion. Extension of the old lesion, no extension of the pre-existing lesion. The Koebnerization is defined as the development of vitiligo at sites of spots, especially traumatized skin. And VIDA score, that is a very important skin that was developed by Enzu et al. level the activity of the disease in individual vitiligo patients for any therapies for at least 6 months. Now, mini grafting, the test was described by Flavella, what the article which was quoting, and in selecting appropriate patients for surgical intervention. On the right side, you can see the VIDA 6-point score, where it was graded from -1 to 4. And you can see activity in the past 6 weeks is +4, where stable at least for 1 year, and then spontaneous repigmentation is -1. So if you have a confetti-like pigmentation, you have a score. You have to be put in the score whether even present or not. A global grading C1, C2, 3. Incorporation is another important, and hypochromic areas are another important areas. So all these things have got points. Confetti-like pigmentation has got right side, there's points. So you have to score the VIDA score. If you look at the stability. Then there are biochemical parameters, a very important thing, significant increase in the plasma urinary concentration of urinary catecholamines, actually, HV and VMA. Higher levels of COMT in the epidermal homogeneous. Significant increase in plasma levels of norepinephrine or normetanephrine. 3-methoxy, 4-hydroxy phenyl glycol. All these are COMT catecholamines. Higher serum levels of malonaldehyde and selenium, and higher RBC levels of superoxide dismutase, and serum levels of granulocyte colony stimulating factor, which is also important, remember, in SGS10 in both focal and generalized type vitiligo, and the IL-6 level in the generalized type was significantly higher in those with progressive disease than those with stable disease. Serological studies regarding the stability. There are also multiple sterilizing serological studies. I will quote only this tyrosine level, tyrosine hydroxylase, and tyrosine related proteins are very important putative antigens in vitiligo. Then there was study at a complement mediated cytolysis melanocytes. So these studies were reported, and a decrease in the antibody mediated cytotoxicity against melanocytes may play a part, particularly when the vitiligo skin is developing after the systemic steroids. So if you look at the epidermis with the microscopic and the ultrastructural correlates, the epidermis of the vitiligo skin revealed complete loss of pigment of melanocytes, while perilesional skin showed vacuolar changes of the basal cells and epidermal and dermal infiltration. There is lower addition to collagen type 4 as also observed in melanocytes from unstable vitiligo compared to that of the stable vitiligo. Caspase 3 and annexin 5 both are markers of apoptosis. Staining was significantly greater in unstable vitiligo. And also we observed higher significant increases in CD3, CD4, and CD8 cells found in margin of vitiligo lesions with most intense infiltration, particularly when the 0.6 millimeter age of the lesion. So these were actually very important things. Now, if you come at the immunocytochemistry, you will find very important things. The active vitiligo is one where there is complete absence of melanin in the basal layer with mild spongiosis. The absence of melanin pigmentation on the Mason-Fontana HMB45 immunostaining shows no melanocytes in the basal layer. Epidermis showing increased number of Langerhans cells in S100. What is a stable? Decreased melanin pigment in the basal cell layer, mild lymphocytic cell infiltrate in the papillodermis, occasional presence of a human melanoma black 45, the HMB45, epidermis shows occasional S100 positivity. So by immunostaining also you can describe whether it is an active vitiligo or a vitiligo. This was an article probably from the Kaurji and Punyas and Kundu, an evaluation of active and stable vitiligo using S100 and human protein. Indian Journal of Dermatopathology in Diagnostic Dermatopathology in 2020. So if you look at the important, what is the most important? The T cells are mediated destruction of melanocytes, vitiligo. And what are the disease? Nevus depigmentosus, they is secondary to aggregation of melanozymes in the melanocytes and a defective transfer to the surrounding keratinocytes. In nevus anaphimacus, what happens? The vasoconstriction of the small vessels. And hypomelanosic ovito, we know is genetic mosaicism resulting in a de novo postdiagotic mutation. So, you know, a vitiligo will present as asymptomatic white, non-scaly macules and patches of distinct margins that fluoresce when you eliminate with Wood's lab. That is how you see a classic vitiligo. And you can differentiate from these things, nevus depigmentosus, nevus anemicus, hypomelanosis of it. You can also go for the dermoscopy. That is a very important tool now. The background color is diffuse white. There is a white glow coming out. the follicle may show leukotrichia, the pigment pattern, the reduced residual, the perifollicular or the perilesional pigmentation, and there is reverse pigment network. So these things actually will help you to diagnose a case of vitiligo. Electron microscopy, you can send absent melanocytes totally. Now, dermoscopic pattern, if you look at the stable lesion and unstable lesion or active lesion. If you look at a stable lesion, it will have a sharp border, diffuse white glow, absent pigment network, reticulate pigment network, perilesional hyperpigmentation, perifollicular pigmentation, absence of satellite lesions and microcobners, and there is another criterion which is not B-leaf criterion, where the cutoff score is more than or equal to 1.5. Now, if you live in an ill-defined lesion, if you have a microcognition phenomenon or cometal appearance, that is called, or peripheral pearly white globules or polka dot or tapioca saga appearance, if you have a starburst appearance or a perifollicular pigmentation, you call it active lesions. So these are basically the lesion dermoscopic features, how to tell which lesion is active, which lesions is now stable. These are the pictures. You can on the left side, you can see a representative dermoscopic image from the margin of an active vitiligo. You can see the tapioca sago appearance, the appearance in white structureless areas, that these are important. And the red area with related important with the perifollicular pigmentation are also appreciated. If you look at the other part, repigmenting lesions, you can see that there are intra or perilesional erythema with telangiectasias. Leukotrichia is there, and marginal hyperpigmentation, which are marked with red arrows. These red arrows are showing marginal hyperpigmentation. So there's a hymn in Atharva Veda which hints that plants abundantly growing during rainy season are remedy for Switra. So these Atharva Veda, from the days of Atharva Veda, we can come out that probably the plant source was important. And we all know of this Vacochia or this important Soralia cortifolia. This gave rise to these melanocyl, the what we use as melanocyl ointments. The Vringoraja, the Indravani, the Rajan, all commented in the Switra Roga. 4 plants actually were commented in the Atharva Veda, and they were these, the Rama, Krina, Askini, and Rajani. So I will come not skipping this. Now, oral steroid maniples, we have all reported described by Persich and then developed by Binod Khaitan and all. And they have leading to perfection. Yes, it does marvelous results, and all the side effects actually were there, but they were mitigated. Side effects were not absent. The side effects like weight gain, insomnia, agitation, acne, menstrual and hypertrichosis were observed as high as 69% of the patients. So, but if you give it daily steroid, probably the incidence is going up to 90%. The use of oral mini-pulse dexamethasone in vitiligo patients, this was a review article where you can show, this is not the Ames paper, these are people of the other, not only the Europeans, the other people, Egyptian people have also adopted this mini-pulse. And probably this was, before the JAKs came into the picture, probably this was the treatment when you wanted to halt a fast spreading vitiligo. So these are methotrexate, already Ovijit was describing. Methotrexate, we use steroid sparing is, yes, methotrexate is a wonder drug, and not only in psoriasis, it is also here, and is a time-tested drug. We do agree. And this was a test where randomized group 1 patients received low-dose methotrexate, 10 milligram per week, folic acid 2.5 milligram. Group 2 patients received oral corticosteroid. On follow-up, the patients repigmentation in each topographical area by standard protocol. So methotrexate can be used very safely in patients with active vitiligo where corticosteroids particularly will be contraindicated. So if you look at the photochemotherapy, so Sorelen and UVA, narrowband UVA, this is very important study which will show that narrowband UVA probably scores over the UV PUVA therapy, but the time-tested puvazole is also there, which is a cheap and can be taken in the villages. You don't need a machine, so there are many advantages of that also. So take-home message from the study was narrowband UVA is the most statistically advantage. We have already told that. So vitiligo working group phototherapy, this is a guideline. Initiate with dose. I'm not going to the details of that, of the phototherapy guidelines. These are the phototherapy guidelines. Now coming to you can see the excellent response that phototherapy patients showed. This was a report from Ravi Shankar, Rathore, and Saikia for narrowband UV patients with vitiligo. You can see the before and after picture. Now, other immunosuppressants, cyclophosphamide is a very important drug. Yes, side effects of hair loss, cytopenia, and nausea are there. 2 into 50 milligram dosage is as assessed in small case of 33 patients, 29% repigmentation was seen, including acral sites, that is very resistant to depigmentation. Cyclosporin, little or no pigmentation, 5 out of 6 patients in this study. Etanercept was used, another important. Before important, yes, Anupam told ritlecitinib. Ritlecitinib is important. I know ritlecitinib. I fought for ritlecitinib introduction in the CDSCO. Unfortunately, some people, members opposed it without a breach trial, and hence it is now still not available. CDSCO approved. So this is a randomized control study to evaluate the effectiveness and DCP pulse. This is oral minocycline active. So oral minocycline is another thing which you can try in a case of unstable vitiligo. Then there are other drugs. This is the aflamelonide, 16 million subcutaneous per month for 4 months with narrowband UVB. This has got wonderful results. Rituximab, latanoprost, monocycline, zinc, and obviously the ZAC inhibitors, tofacitinib and ruxolitinib, and then now ritlecitinib and other things are coming into the market. Statins have shown very important effect. IVIG, equimolar IVIG is a wonder drug. Azathioprine is a very important thing. So all these drugs are very, very important. You can also, the Chinese important ginkgo biloba, piperazine extract, stem cells may be the future. Inducible HSP17, CXCL17 and CXCL3 blockers, L-phenylalanine, all these things. Then UVA with phenylalanine and topical minoxidil, a new modality in unstable vitiligo. This was a study we administered 50 to 200 milligram of phenylalanine, a precursor of tyrosine, approximately 45 minutes before UV radiation. And this was none other by our C. Srinivas. The article was important acceleration of repigmentation of vitiligo by topical minoxidil in patients on phototherapy. This is a report in International Journal of Dermatology way back in 1990. Now, unstable vitiligo is special population. You can see that how pediatric vitiligo already had a detailed description. Vijit has taken it so detailed. So I'm not skipping this. I also skipping this. Systemic drugs used in childhood, oral minipulse, methotrexate, azathioprine, yes, mycophenolate mofetil, cyclosporin, apremilast, and the JAK inhibitors. So vitiligo in pregnancy, is there a change in outcome? Pregnant women with vitiligo was significantly as with increased risk of abortion and systemic treatment before conception and could improve pregnancy outcomes. Reassurance as to the benign effect of vitiligo on the fetus and low rates of vitiligo transmission can be given to pregnant vitiligo patients. Limited treatment interventions in vitiligo in pregnancy are available for the time being, which may include topical corticosteroids and phototherapies. Folic acid supplementation, particularly advised for women in conjunction with phototherapy. And prostaglandin F2 analogs, psoralen, minocycline, cyclosporin, azathioprine are category D drugs, so they should better be avoided in pregnancy and lactation. This is a very important recently FDA approved drug, which I was describing, this ritlecitinib, where we can have a new drugs. There are biologics new coming up, targeted therapies in vitiligo, and we should keep ourselves updated where we can arrest them as and when. Improvements of immune melanocyte biomarker with JAK3-TC inhibitor, ritlecitinib that I was telling. So therapeutic algorithm for the management of vitiligo, you can go by this algorithm or you can find your own algorithm. There is no other thing, but this algorithm still contains the oral minipulse, which is still we are proud of. It was found not developed by EMS, and then all the sahibs or the Gora Chamras started to emulate them till this now ruxolitinib and this ritlecitinib are coming to the picture. So conclusion, the management options of vitiligo have undergone a sea change for the last 2 or 3 decades. Treatment options such as narrowband UVB, targeted phototherapy, excimer laser on the medical front, in addition to epidermal cell transformation and melanocyte transplants in the surgical fronts, have all revolutionized the vitiligo, this stigmatizing disease, I'll call. Oral minipulse along with other newer immunomodulators and topical agents from the main basic core, they arrest the progression of the disease. Thank you.
Thank you, Dr. Sudeep, for a wonderful talk. Now I would invite Dr. Shreya Poddar, who will be conducting and moderating the panel discussion. So over to Shreya, please.
Thank you, sir. Let me just share my screen, please. Is it visible now?
Yeah, it's visible.
Okay, thank you, sir. So good evening, everybody. It's a privilege to be moderating this panel session on management of difficult vitiligo. And to share their expert insights, I have a set of esteemed panelists with me today, and I would like to welcome them all. Dr. Aditi Chakrabarti ma'am, Dr. Shomu Panda sir, Dr. Vikas Ranjankar sir, Dr. Indrashish Poddar sir, and Dr. Shuchibrata Das sir. So without any further delay, let's start our panel discussion on difficult vitiligo. So vitiligo in itself is a very enigmatic condition, and each case in itself is unique and challenging. But then there are certain clinical scenarios where we find our backs against the wall and we find ourselves in a puddle. So it can be a rapidly progressing case. It could be a generalized or a universal vitiligo. It could be difficult sites such as acral mucosal. It could be when we are dealing with special populations such as children or pregnant females. And we all know vitiligo has an association with other autoimmune conditions. So it could be two disorders coexisting together. And then, of course, the most important of all, the psychological burden, which is the most difficult to handle. So let's begin our session with a clinical scenario of a rapidly progressive case. So this was a 19-year-old female who had presented to me, and she had her age of onset of vitiligo at 18 years of age, and the disease was rapidly spreading in the last 6 months. So I would like to start my panel by asking my panel. So I'll ask Aditi ma'am, ma'am, how do you assess disease activity in a rapidly progressive case of vitiligo? How do you assess it clinically first?
Okay, I mean, the clinically would also involve history. So any history of new lesions appearing or extension of new lesions, the history of Cobnus phenomenon. And on examination, I would look for trichrome. I would look for, confetti-like depigmentation, ill-defined hypopigmented areas, or inflammatory, redness or inflammation around the vitiligo sites. So those would be the things that I would consider.
Right. So Bikasa, would you look for anything else apart from what ma'am mentioned?
No, I think in our real practice, we hardly do all these dermoscoping and other tests. What we rely on is mostly the patient's history. Patients say that all these things happened over a period of couple of weeks or months. So that is a good enough evidence to conclude that probably they are very active and rapidly spreading.
Right.
In case we are in doubt, we have certain methods to establish, like ma'am has already mentioned. So maybe we can follow them.
Right. And do you get patients of vitiligo who complain of itch? Because this paper said that itch was also a visible sign, clinical sign of disease activity. So have you gotten patients where they complain of
Yes.
itch?
They complain of itch, and itch is a very good marker of clinical activity in vitiligo.
Activity as well. And what about leukotrichia? Do you take it as a reliable marker of activity?
Leukotrichia, yes, but again, that is a double-edged sword because sometimes in repigmenting vitiligo also, you have persistent leukotrichia.
True.
So whether that can be taken as a marker of disease activity or not, it's very difficult. You would correlate with other evidences as well.
Okay, right. So when we talk about clinical signs of disease activity, as our seniors have mentioned, Cobnus phenomenon holds the strongest evidence, and that is taken from a patient's history. Confetti-like depigmentation is gaining now foothold when assessing clinically for activity of disease. Then there are trichromic, hypochromic lesions, inflammatory borders, and itch and leukotrichia. Okay. Now coming to dermoscopic assessment, Shomu sir, do you do a dermoscopic assessment in your practice for vitiligo?
No, never. I mean, basically, I do not think that other than clinical assessment, anything else is necessary.
Okay.
And basically, if I cannot appreciate the polymerization or hypochromic or ill-defined lesions,
Right.
I mean, and expect to identify, quote unquote, tapioca sago in dermoscopy. I think it's an insult to intelligence, frankly. I mean, clinical assessment, and clinical assessment. That's all.
So you just rely on clinical assessment while
Absolutely.
Okay.
Absolutely.
Shuchibrata sir, any experience with dermoscopy in vitiligo patients?
Not doing regularly. I am completely agree with Somo sir actually. To us, actually, clinical activity is the sole indicator of diagnosis, prognosis, treatment, moderate to fix actually. Rarely did dermoscopy in vitiligo patients, mainly in the active stages actually, when the patients are coming with progressive vitiligo. What we're seeing actually, the main important problem is the change of the reticular pattern, pigment pattern is the main that indicates the progression or of the disease activity. At the same time, we can see the perifollicular pigmentation. If it's pigmentation or hypopigmentation, that leads to the it's a disease activity. If it's hyperpigmentation, that means the patient is going to be repigmented. If I get the trichrome, it gets the telangiectasia, all are going in favor of the activities, disease activity.
Okay. Okay. So yeah, there has been studies, a lot of them actually, to see signs of disease activity with dermoscopy, and they have mentioned, and Sir Sudeep sir was also mentioning, so ill-defined margins, comet tail appearance, tapioca sago appearance, starburst, and perifollicular depigmentation have been found to be associated with active disease. Right. So these are some pictures where we see the starburst pattern and the tapioca sago appearance. Now coming to biomarkers. Indrashis sir, do you have you done any histopathology for vitiligo patients and come across findings that are significant of disease activity, or any sort of biomarker that you have used in research or in your practice?
No, not really. I think histopathology, I don't think I have ever done in a vitiligo patient.
Okay.
And biomarkers, I am aware of several biomarkers in the literature, but I
Right.
think they are more of a theoretical interest rather than practical purpose, because as it has been already discussed that we can easily identify active vitiligo from the clinical history, and then dermoscopy can be done just as a supplementary tool. I mean, I agree with Shomo sir that it's not necessary to diagnose. I mean,
Yes.
I have already got a active disease and I have a dermoscope in hand, so I may do it actually. So
Right.
that's
Right.
the only point.
Right.
I don't think that we do this kind of biomarkers in vitiligo. At least I don't do them. The facilities are actually not available at my center, honestly.
Aditi ma'am, yes.
Just I want to add, Shreya, just want to add. Actually, biomarkers are very specific to vitiligo. Actually, so no specific. That is the only we can not like that. They are vague, and any inflammatory conditions that may raise that markers actually. So difficult to.
Another very important thing is for any kind of biomarker to be adjudged to be useful in assessing disease activity or for whatever purpose clinically, it will require a huge multicentric trial across populations. And I do not think anything near that has been even attempted in vitiligo as far as biomarkers are concerned. So basically, we do not have any kind of evidence to guide our treatment protocol or management protocol by means of biomarkers in vitiligo.
Aditi ma'am, you were saying something.
No, I really just wanted to know if anybody is actually doing it in their day-to-day practice, because to me, these are research tools and available in very specific or, very tertiary care centers. It's well beyond our day-to-day practice. So no, never. I mean.
Okay, ma'am. Because so your final
Yeah, I
take on
completely
biomarkers?
agree. We do not have access to all these tests,
Right.
but maybe for research purpose, someone can take it up, and it needs a huge database of patients and their biomarkers to validate the entire set of biomarkers.
True. And talking about histopathology, like have any of you done biopsy for any case and for what purpose?
Possibly the only time I've done a biopsy is to rule out lichen sclerosis, because sometimes it can be
Exactly, ma'am. Exactly.
especially, I mean, even on the body or on the genital mucosa, vulva in women, you know, so that's about the only time. Otherwise, no, never.
Differentiator mimicker. That's the only time when you
There is one more condition like hypopigmented MF.
Yeah.
So maybe that is also one mimicker.
Right.
Yeah, I was talking of something we see more commonly than hypopigmented MF. So I think lichen sclerosus would be, if I can't differentiate between the two.
We can think about the EDV also. Sometimes it also may confuse with vitiligo.
Yes, yes.
Yeah, so basically when you think it could be vitiligo or it could be one or the other thing, that's about the only time. But when you know it is vitiligo, and I agree completely with you, clinical is enough for that. There's no point in doing a biopsy.
Right. So, lastly, coming to scoring systems, are they feasible in practice to assess disease activity? Shuchit sir, you can take this question.
Scoring system for disease activity, definitely, it's not very much effective actually. The VIDA score, what Dr. Sudeep actually mentioned, that is definitely disease activity that will help. The European task force, that is not very useful because we're not doing wood slam every time in the daily OPD or a procedure. It may definitely help, but I think it is not clinical. What Dr. Musa told actually, clinical evaluation of increase or progress or improvement of the therapeutic, there is, I think, enough for treating a vitiligo patient.
Even while like assessing the prognosis to our treatment, we don't do a scoring system.
Yes.
Because, sir, what is your take on it? Like our scoring system.
I think out of all these, I use VIDA at times, especially before taking a patient for surgery. And otherwise, most of the time I clinically assess them, and VASI score is only limited to if at all any thesis or research project is going on. So in that case, only we monitor.
Okay.
Priya, can I mention that I keep, or I try to keep photographs of patients so that, you know, instead of doing a scoring system, I look at photographs and then compare it when the patient comes back for a review. I find that much more useful.
Okay. Shomu sir, your take on scoring systems for disease activity?
Only if we are doing a research project. I mean, it's of purely academic interest and definitely quite useful if I am doing a study. Otherwise, in day-to-day practice, I do not think no. I do not think that none of these are meant for use in day-to-day practice. These are basically, they were devised to be of help in research activities. And obviously, then we need to put objective scores, and definitely I would need it, but otherwise, no.
Okay. So just to complete the list, we have certain scoring systems for activity, which is VIDA, and then we have KV score, which is Keebler phenomenon and vitiligo score, and we have VSAS, which is vitiligo signs of activity score, and we have VDAS and VDIS, which all of which were covered in detail by Sudeep sir. So now I'll move, once now we have assessed disease activity, and according to our panel, clinical activity is just sufficient in our day-to-day practice. Even dermoscopy is not of much use, and biomarkers and scoring systems are purely for research purposes. Now, Indrashi sir, what would be your approach to arrest disease progression? Like, which would be your preferred immunosuppressant, and which dose you will be giving, what duration, and when will you start tapering that immunosuppressant?
For me, the choice is obviously oral minipal, betnizole, betamethasone actually, basically. So the twice a week schedule, basically for 1 milligram for 10 kg. That's what we have been taught. 1 milligram tablet is available. That's for 10 kg body weight. So that's how we give. And then taper it because that's twice a week, and then we gradually taper it by seeing the response.
Start to taper it? Like
I actually give it, the interval is usually 4 to 6 weeks. So I usually give it at a single dose for 4 weeks, say, and then I slowly taper it. Every 4 weeks, I usually taper
maybe
it.
After
and
4 weeks. So even if after 4 weeks the patient has not achieved disease control, if it's still increasing, what would be your next step?
Okay, so in that case, suppose we have already exceeded the maximum dose of oral minipal. In
Right.
that case, I think nowadays, of course, tofacitinib is very handy. So what we do is now that we start with oral minipulse because that is quick acting, and we also send the patient for the baseline investigations. So within 4 to 6, so once the patient returns with the investigations, and if the disease is still actively progressing, we go for tofacitinib. And we all know that tofacitinib takes about 4 to 6 weeks to start its action.
Yes.
So I think oral minipulse will cover that period till the time tofacitinib takes up, and then we slowly taper, and by that time tofacitinib is already functional. So I
Okay.
think that's the
That is
approach
your way
nowadays. But
to go. Okay.
yeah, but I think I should say that tofacitinib, it needs some kind of phototherapy because it is already well known that tofacitinib only acts on that immune pathway. It basically it takes care of the autoimmune mechanism, but melanogenesis has got no role with tofacitinib. So I think with tofacitinib we always need an adjunct, some sort of phototherapy.
But does melanogenesis have any role with any of these oral medications, Aditi ma'am, like, or we need to add some sort of therapy to induce repigmentation?
I think phototherapy along with them, especially narrowband phototherapy or excimer laser, if possible, that would help. Cyclosporine was discussed as increasing pigmentation in the periprocedural.
Yes.
Yeah.
Yeah, it has a periprocedural role,
yeah.
yes.
But I think oral minipulse can also induce some amount of repigmentation other than halting the progression of the disease. And for oral minipulse, there was a good study by Kanwar et al. From PGI where they used 2.5 milligrams of dexamethasone on 2 consecutive days and found it to be similar in effectiveness to 5 milligrams. So I tend to use 2.5 milligrams.
Okay.
On 2
2.5 of dexamethasone, 2 consecutive
on
days.
2 consecutive days.
This is your go-to immunosuppressant.
And I would add on, I am a little conservative as, adding tofacitinib onto anything. I still think it's not really first-line medication as yet. And there are side effects that we need to consider. And the more it is being used, more side effects are being added. So I could use low-dose methotrexate. Or sometimes have, so basically for disease progression, it would be oral minipulse with low-dose methotrexate for me.
That will be your choice. Because, sir, your preferred immunosuppressant?
Yeah, during active phase, I go for minipulse, or even for that matter, maybe regular steroid therapy before I taper it out.
Okay.
And once I step down, I switch over to azathioprine usually. I have used cyclosporine in pediatric age group. MMF I have not used. Tofacitinib, I have found it useful only in the photoexposed areas. So I don't think it is superior to other molecules, whatever other molecules we have now. Because phototherapy is probably doing the greater bulk of repigmentation there. And I do not have any experience with minocycline.
Minocycline, sir, apremilast?
Apremilast I started giving to patients when apremilast was introduced, but it disappointed me, so I stopped.
Okay. Shomu sir, quickly your preferred drug?
Definitely oral minipulse is the go-to drug, particularly in a rapidly progressive phase. And tofacitinib, I have used both the oral and the topical, but somehow I'm not very impressed. It is nowhere as effective as in, say, Shariata. So that is my take with tofacitinib. And another molecule which is very, not highlighted at all, and which I resort to if for some reason I find oral minipulse or steroids are contraindicated or not advisable, is methotrexate, which works particularly well and is relatively cheap. And even in children, the safety profile is very good. So
that's true.
So basically, that's my go-to drug.
Okay, sir. And
Shreya, may I come in? I'm Dr. Abhijit. May I come in?
Yes, sir, for sure.
Yeah. Sorry for the interruption. I just want to echo Somo sir. We have been using oral minipulse along with methotrexate we have been using for quite a long time, and it's extremely efficacious. This combination is, and I mean, and similarly, it is very much safe combination because you can start with oral mini pulse. Methotrexate will take some weeks to give its efficacy. So there will be an overlap period of few weeks. Then you gradually taper off oral mini pulse and continue with the methotrexate. As I've so we have been using it for quite some time. We have used in many patients. This combination is really wonderful and cheap. So there are multiple benefits of this combination in our kind of patients in resource poor settings.
Right. Thank you for your input, sir. Shuchiprata, sir, when do you stop all the immunosuppressants? Like till like how many months after patient has achieved activity, achieved inactivity?
Yeah, actually, I'm just following that the lesions, the activity of the lesions subsided, and there is a repigmentation started. This is the main guideline what I follow to I mean, taper or to stop the immunosuppressants.
Right.
So when you're saying that the erythema or progression or other trichrome are all subsided and this the follicular or marginal repigmentation started, then I plan to reduce the doses of the minipulse tapered and takes few months to stop it. At the same time, I'm introducing the other medications for repigmentation.
Okay. Okay. So yeah, oral immunosuppressant, like our panel said, we have to hit early, but again wisely because they can have side effects also. Corticosteroids have maximum data, but minipulse has been shown to have some intrinsic repigmenting property, as ma'am mentioned. Cyclosporine can cause arrest of disease activity and has a periprocedural role. Methotrexate works extremely well. Azathioprine can be added once you have tapered off the corticosteroid as per our panel. And cyclophosphamide, of course, has a risk of pancytopenia. MMF, they have not used. Minocycline, again, it has been found in a paper that there was significant reduction in VIDA with good repigmentation. And tofacitinib, like our panel also mentioned, has better results in photoexposed areas. Apremilast, the data is limited. Right. Oral antioxidants. So I would like to begin with Vikas, sir. Do they just add to the prescription cost, or should they be added in unstable cases or in vitiligo cases in general?
A lot of data, but all of them they are accumulated in the either in the late 80s or maybe 90s.
Okay.
So I do not think the data is sufficient enough. And we have evidence that reactive oxygen species do play a key role in the disease activity. But as of now, if you scan or probably scrutinize few of our prescriptions, hardly anybody gives emphasis on these antioxidants. I give, but not as a first line therapy. So topical or oral, mostly oral. So it's a second line or a adjunctive therapy, not as a first line.
Okay, okay. So yeah, there have been papers where oral gliadin protected SOD has been proved beneficial in addition to phototherapy. And likewise, there was a paper where, polypodium leucotomus extract with narrowband UVB was beneficial in treatment of vitiligo vulgaris. Okay. And lastly, what about vitamin D supplementation? Shomu sir, do you do a vitamin D level or do you supplement for vitamin D?
No, never.
Never.
I basically all the vitamin D data. I mean, they are mostly association studies.
Right.
Association studies with low levels of vitamin D with vitiligo. I mean, that way you can find out association between anything. I mean, person who travels by tram, they can be found to be associated, greater association with vitiligo and so on and so forth. I mean, all kinds of absolutely fictitious associations can be found out, but there are no studies which have categorically shown till now that vitamin D supplementation can actually reverse the course of the disease or reduce the disease progression or induce repigmentation in vitiligo. There is no evidence at all. So I do not think that vitamin D supplementation has any role in vitiligo.
Okay. Indrashis sir, any take on this vitamin D supplementation in vitiligo?
No, I don't do it actually. I completely agree with Shomo sir. This is,
Okay,
I mean, very little evidence, so I don't do it.
not required. Okay. Aditi ma'am, when to consider total depigmentation and who would be a suitable patient for total depigmentation?
Well, somebody who has universal vitiligo with patches of, pigmented areas, that would be the patient for consideration. But most importantly, the thing to see is the psychological aspect of the patient and the fact that they need to understand that, once this area is depigmented, there never can be repigmentation. So that counseling is very, very important. So somebody who's very motivated is almost, generalized. Somebody showed a picture just now, almost generalized depigmentation. Those would be the candidates, but they have to be very motivated and counseled well.
Right. And Shuchibrata sir, which drug would you give and what duration, and how would you ask the patient to apply it and counsel them regarding that drug?
Yeah, actually, it's a difficult situation to take to our counsel. I mean, tell the patient, because the universal vitiligo patients, after some time, pigmentation appear in the most sun-exposed areas. Actually, the typical face where it is exposed all the time. So it is a difficult situation. It's a cosmetic problem for the patient. So usually patients are coming that, sir, these lesions are looking very bad. I am not going out. So this is the main motivation for the patients, that they cannot go out. So we have to counsel a lot before starting the depigmentation treatment. That
And which drug would you be giving, sir?
yeah, it is a monobenzyl ether hydroquinone.
Yeah.
It is using applying. Starting with a very low dose short contact therapy and gradually increase, and say 3 to 6 months or more than 6 months is required to get a result, complete depigmentation.
Okay. Okay. And what about physical therapies? Because sir, Q-switch lasers and cryotherapy for depigmentation. Any experience or any
Yes,
word
yes,
on
I
that?
have experience of resistant islands of pigmentary changes, especially the refractory cases where they go to sun and get back that pigment on the face. The prior Q switch, and I was successful to some extent. But
Okay.
counseling regarding sun exposure induced pigmentation is a must.
Okay. 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 Great. Now coming to a different scenario where we get mucosal vitiligo and acral vitiligo, sites that are difficult to treat. So, what are the treatment options that you consider in these difficult sites? Shomu sir, if you could tell us.
Yeah, basically, for example, this left-hand panel, stable mucosal vitiligo in women around the genitalia,
Yes.
for example. So that is, I think, the first option that you have given, that is
Yes.
5-FU intralesionally
Yes.
with microneedling. If
Yes.
that can be offered, I think it works very well.
Okay.
And the only complication is the pain, which is complained by not all, but a section of the patients. So, but on the whole, I think because this is an area which is not very amenable to,
Repigmentation. Yes.
many other different kinds of therapy,
Yes.
and particularly your tofacitinib and those things. And I mean, basically because these are absolutely unexposed areas. So I think you have to think out of the box in these situations.
Okay. Okay. Aditi ma'am, your take on this side?
Really, if somebody with that sort of genital, I mean, affecting the vulva comes to me, I would first try to counsel the patient and, ask them to avoid any therapy because it's really difficult in these areas. If the patient is absolutely adamant on using therapy, then maybe topical calcineurin inhibitors along with targeted phototherapy, maybe. But my first go-to would be to counsel the patient out of seeking treatment.
Okay. Okay. And Vikas, sir, your take on these cases?
Yeah, I do agree with my colleagues what they told. But in patients, they usually demand some therapy for these areas, especially marriage proposals are pending or something like that. So difficult situations. So we need to counsel. And I do a lot of therapeutic wounding with phenol. And it's very successful, especially in lip areas, as well as if you have small areas in the glands or some maybe in the superficial skin, that works.
Okay. Okay.
What percentage phenol do you use, Dr. Bikash? What percentage of phenol? 80?
The complete phenol.
Phenol, total.
I do not dilute it because more dilution of phenol causes more penetration.
Okay.
And what about the phototherapy in these areas? Shuchibrato sir, phototherapy for these areas?
Actually, just my opinion is mucosal area is the most resistant site, and any medical therapy they will give no result. Even to making trauma and making PIH, because there is no melanocyte after all, no hair follicle. So from where will get the pigmentation? My opinion actually for therapy, you can go for surgical like either mini graft or maybe the culture, melanocyte keratinocyte culture. It's difficult to keep in the place, but only this method will give you a good result if the patient needs genuinely. Because other methods, I think, where you will get the melanocyte. Phototherapy, I definitely not advise the patients, both in the left side pattern, the female patient, both in the acral vitiligo. In acral vitiligo, I'm going for the punch. It's a very good result actually, punch grafting.
Okay. Okay. And Indrajit sir, any experience with excimer lasers in acral cases or mucosal cases?
No experience with lasers.
Lasers. Okay. So yeah,
Can I come
lasers.
in?
Yes, sir.
Excimer laser works again, it's just like any other modality, only with the rapidity. So head and neck, it works better, but it also fails in the acral areas. So we do not say that it works better for the acral areas.
Okay. Okay.
So maybe only you can expedite the entire process of repigmentation with excimer.
Okay. Okay. And sir, any use of ablative lasers, CO2 lasers, in
Ablative
acral cases?
lasers is for dermabrasion we have used for before surgery or during surgery for dermabrasion. We have used along with PRP, so we have few publications on that. But they are not to be practiced routinely. So probably that was a part of the research protocol that I am taking.
Okay, okay, got it. Yeah, so there has been papers where combined excimer light and topical calcipotriol has been found to be effective for acral vitiligo. And then, like Sir mentioned, CO2 in combination with 5FU or microneedling with 5FU can be done on hands and feet. So this was one protocol where 5FU is applied daily for 5 months and CO2 laser treatments is given once a month for 5 months. This was something that was suggested by BJD. Now, vitiligo at the angle of lips. So this is your paper only, Bikash sir. So if you could suggest, give your take on it.
Yeah, basically this is equally stigmatizing. People who have vitiligo, even if it's small, 2 to 3 mm, but it shows. So anything on the face which looks short is equally stigmatizing. So we need to address that. Recently, I am working on this phenol therapeutic wounding with phenol. And before that, I was working on radio frequency ablation followed by 5FU. And that gave me very good results.
Okay.
And let us see how it comes out. Earlier, I did publish this large series of 112 patients with suction blister grafting. And the suction blister grafting to me is the best method till date. More than 70% patients that repigmented. And the pigmentation also persisted. We followed them for more than 1.5 years and it persisted. So that is probably the best till date, what I have seen.
Okay, okay, right. Now moving on to our third clinical scenario, which will be of pediatric vitiligo. Now this was discussed at length by Abhijit sir, but still to shed some light on it, we get a lot of cases of pediatric vitiligo. So Shomu sir, at what age do you initiate tacrolimus or pimecrolimus for these patients?
Well, basically, it all depends when the patient comes. There is no lower age limit. If you look at the evidence, I mean, there is a very large study, as far as I recollect, from Japan, which sort of established that it is tacrolimus 0.03% is safe and effective even in children less than 6 months of age. So, whereas there is a diametrically opposite study which sort of seem to suggest that in children less than 16 years of age, one should not try to give even tacrolimus 0.03%. So I basically am guided by my clinical experience, and I think that tacrolimus, particularly at a lower concentration, will not do any harm in particularly because vitiligo in infancy is a rarity. So mostly we get children, maybe young children, not that much, but mostly older children. And there is no problem with tacrolimus and pimecrolimus being instituted.
Okay. Indrashit, sir, your preferred topical agent for kids, which one would you initiate for these patients?
I completely agree. What I do usually is less than 2 years, I usually give pimecrolimus, and more than 2 years, I give tacrolimus.
What
And
strength?
tacrolimus, 0.1%. I think personally that 0.03% doesn't actually work. There are many publications also. So I usually give, but I only give 0.1% in more than 2 years. And before that, I give pimecrolimus.
And no topical steroid in these patients?
Topical steroid, sometimes I do. I give the weekend therapy, 5 days of tacrolimus or 5 days of calcium inhibitor and 2 days of topical steroid. So nowadays, initially I used to give topical steroid 2 times a day, but now it's already known that 1 time is sufficient. So it's easy for the patients to understand. 2 days a week, maybe in the weekends, topical steroid, and the remaining 5 days, topical calcium inhibitor.
Okay. Aditi ma'am, your preferred topical and immunosuppressant in children?
I don't recall having patients below 2 years of age, but for the older children, I often give a topical corticosteroid once a day and a calcineurin inhibitor once a day, and then eventually, stop topical steroids after 4 to 6 weeks of treatment. And topical steroids, I just give once a day for any condition now. So.
Which steroid do you give exactly? Which potency?
Depending what I'm using, I would still tend to give something like mometasone, because there's no point in giving weak steroids. It may not be of any use. It's better to give at least mometasone and, review periodically to see. But as I said, I generally don't give more than 4 weeks at a stretch, and with a calcineurin inhibitor.
Okay. And Shuchibrata, so your preferred immunosuppressant in children, oral immunosuppressant? For untreated cases?
Yeah, I prefer oral corticosteroid in menopause mode actually. Never tried other in very small child. Just one thing I want to mention: 1% tacrolimus, it causes irritation in the mucosal area, say around the eye leads or around the lip mucosa. So we have to ever say the mother of the child. At the same time, use emollient cream actually to reduce the irritation part. That should be kept in mind. It causes definite irritation.
Okay. And because, sir, any experience with oral or topical tofacitinib in this age group?
Yes, I have used, but as I told earlier also, tofacitinib works only in the photo-exposed areas. So I have tried giving it in the other areas which are usually covered, and that doesn't work. But head and neck regions, they pigment first, and the rule applies to all. Means the lips, they remain refractory, the acral areas, they remain refractory. So probably it will be an alternative, not a superlative molecule.
Okay. So yeah, there's very little evidence published for pediatric vitiligo, and we had a lot of discussion in the talk as well. And phototherapy, what about phototherapy? At what age do you initiate phototherapy in children? Narrowband UVB at what age? Because so?
At the earliest stage when the patient can stand inside the chamber.
Okay, great. So now coming to segmental vitiligo, Shomu sir, what would be your preferred agent for segmental vitiligo?
For segmental vitiligo, we have 2 settings. So one is the segmental vitiligo, which is static, and the other one is there is a disseminated form of segmental vitiligo. Means the segment starts with segmental vitiligo, but later on it disseminates. So if we fall to the second category, then probably I will follow follow up with OMP or for that matter any other immunosuppressive.
Right.
But if it is static, I will definitely wait till the lesions are convincingly static before I go for any surgical reintroduction of pigment.
Okay. Shomu sir, your take on segmental cases?
Yeah, more or less the same as Dr. Kaur has suggested. Basically, I have to be sure that it is absolutely static before I suggest any kind of surgical intervention, because otherwise that would be a failure. And the thing is, mostly, for example, in the left-hand panel, whatever you were showing,
Yes, sir.
I mean, I have seen a great deal of improvement simply with topical corticosteroids in
Right.
quite a few of these cases.
Right.
So it most often it requires nothing other than that. You have to be a little bit patient. You have to counsel the patients and their parents to be a little bit patient, and then
Right.
it works.
Right. So yeah, I actually gave just topical tacrolimus to this girl, and it had a wonderful response.
Right.
Aditi ma'am, anything else that you would like to add for segmental cases?
No, not really. As everybody said, segmental vitiligo, it needs to be stable before you can offer any surgical measures. So stability, tacrolimus, topical steroids, maybe because it's on the face, even topical tofacitinib.
Can be given. Yeah. Okay. Indrashi sir, coming to this scenario of a pregnant female with unstable vitiligo, what is your approach going to be?
I think in these cases, oral mini pulse, I think, is the only thing which can be given, but that's only when it's extremely aggressive. First
Okay.
and foremost, I think we need to counsel the patient about their condition. I think most patients understand. I think, very rarely patients actually tell us that they need some systemic medication. Most of them are aware of that condition, and they're very eager not to take any systemic medication. So I think it's the right thing to do. Also, it's a very special condition, so it's not really wise to go for vitiligo. You can treat that after the baby is born. You can treat that forever. So I think that's the main counseling, to use only topical therapies. But if it is absolutely necessary, extremely aggressive case, very rare, and that too not in the first trimester. In the first trimester, I'll never use any systemic drug for vitiligo. So that's sure. But after first trimester, then I may think of oral mini pulse, because that is category B. So I may think of oral mini pulse. Yeah.
Yes. Shuchibrata sir, your take on vitiligo in
Yeah.
pregnancy?
Pardon, this patient in with pregnancy.
Yes.
I never give oral corticosteroid. There's the early maturation of the cardiac and other organs. So, if just at the situation at the very late trimester, or patient going to labor or then I can only think about the oral corticosteroid. I put the patient on the phototherapy, narrowband, if possible. I just put the very safe without causing any harm to the patient. And the lesion, if not very, very large, I can give topical steroid. If large area involved, I'll never give topical steroid also. Wait, counsel the patient, and take time after delivery.
Okay. Okay. Aditi ma'am, your take on these patients?
Well, narrowband phototherapy can definitely be advised, but it would need for this pregnant lady to come thrice into, go somewhere for the phototherapy, to be given, which I don't think is convenient. I would agree with what Dr. Shuchibrata said. Stick to topical therapy if it's a limited disease, and later on, once the patient has delivered, to go for more specific therapy.
Yes. Because what topical and oral medications work well with phototherapy in your experience?
Almost all, means starting from corticosteroids to tacrolimus to vitamin D analogs, then tofacitinib oxalate. So everything works well in combination with phototherapy. Basically, there are two components. One component is the immune component, which is taken care of with these molecules, and second one is the repigmentation component, which is taken care of with the phototherapy. And they work synergistically. So the combination is always better than monotherapy, except the combination of probably cyclosporine with phototherapy, which is avoidable. Other things are fairly well accepted.
And what about this home-based phototherapy cream that has recently become available, sir? Your experience with that?
Yeah, I also give them the Amazon link to buy a handheld narrowband phototherapy unit, which costs around 6 to 7,000 rupees. And it works well. And if you counsel them not to get how not to get blisters, then also it works well. So
Right.
they should start from maybe exposing 1.5 minutes in the initial days and go up to 3.5 minutes max.
Okay.
And that works well.
Okay.
Yeah,
So-
can I come in?
Yes,
Just a
sir. Yes, sir.
What I think is that firstly, there's another new molecule which there are 2-3 papers also now. Crisaborole. Crisaborole is also working very good in localized patch vitiligo. That is one of the experiences I've been used in 3-4 cases, and results are not that bad. Results are good. The
Okay.
second thing is that regarding these home remedies, was the Bikash was telling, these home remedies, yes, they work, particularly in the type when the fingers are affected. I have 2 patients where I'm giving it in the finger, just typical on the fingers on the. I've given the asking on the brush type on that home remedy, this vitiligo, this home phototherapy or home brush phototherapy, whatever it is. So it is working well. It is having repigmentation.
So crisaborole, how, like twice daily you gave for how long and you noticed repigmentation?
After 6 to 8 weeks, there was at least some pigmentation was coming back. And
Okay.
3 months, the patients was gratified. You can compare. I need to do a larger study to compare with tacrolimus or whatever it is.
So it was given as monotherapy, sir, crisaborole?
Crisaborole monotherapy.
Okay.
That is localized patchivity.
Okay. And I wanted to ask about that home-based cream where you apply that cream and then there is immediate exposure for 15 minutes. So, Shomu sir, any experience with that phototherapy home-based cream that is now available by a company?
Yeah, no, I have not yet found the opportunity to test it in any of my patients.
Okay.
So no personal experience.
So yeah, are you asking the this photo stable?
Photo first, sir.
Photo first.
Yes.
Yeah,
Yes.
that I've been using the 2 companies now, not one company. Another
Okay.
company is also there. I'm forgetting the name.
Okay.
Another company has also come up with the same molecule. In fact, they are the manufacturer. Erisocnet is purchasing the molecule.
Okay.
So that is the thing. So that I have used in now in many of my patients. Pigmentation is good. The chance of EA is less. That is phototoxicity is less. That is good. But
Yes.
the rate of pigmentation that comes with melanocyl ointment is much faster than this photo first.
Okay. Okay. That's a valuable take-home point. Okay.
Shreya, may I
Yes.
come in?
Yes, sir, for sure.
Yeah, regarding that, I mean, in putting a child into the UVV chamber, when to put at what age, that actually this point has been discussed several times in ISPD conferences. Now,
Okay.
if that child can be made to sit on the lap of a mother, then also he can be put into the chamber. Even a smaller child, who is not that much capable to stand alone. Even those cases we can also put into the chamber if the child can be made to sit over the lap of the mother with all photoprotective gears.
Okay. 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 Thank you, sir. Coming to second last scenario, which is vitiligo and its autoimmune association. So this was a female patient of mine, a 15-year-old female who had co-localization of scalp psoriasis and unstable vitiligo, and she also had raised anti-TPO antibody. So Shomu sir, how are you going to manage this condition?
Well, this is a condition in which I might try oral tofacitinib,
Okay.
provided there is no obvious contraindication or the baseline tests are all normal.
Okay.
Because both these things, you see, because oral minipulse is a no-go. I mean, because of the scalp psoriasis, you never know, it might develop into a pustular form and whatever. So definitely oral tofacitinib is one thing. And again, considering the age and considering the conditions, methotrexate. Once again, never forget about it. So oral tofacitinib and methotrexate, right?
Yeah. So, in Rishi sir, vitiligo with areata, if that were to coexist, which drug would you give?
I think again, tofacitinib would be a very good option because it works really well with alopecia areata. In fact, alopecia universalis also there are,
Yes.
after 4 months, 5 months, there is very good result. So I think in this case, yes, oral tofacitinib is a very good choice.
So for both conditions, oral tofacitinib can be considered as a first choice, right?
I think vitiligo is so yes, methotrexate will be my first choice.
But why not
Uh,
oral minipulse?
Yes, sir,
Sir?
even
In psoriasis, actually, we avoid systemic steroid. There's a
No,
chance of
psoriasis.
rebound phenomenon. For that reason,
Alopecia
for
areata.
areata,
Vitiligo and alopecia areata.
yeah, tofacitinib, definitely.
Definitely go for
Minipulse
minipulse.
and tofacitinib, definitely.
Yes, yes,
Yes.
yes.
And another question, like, do you routinely screen for thyroid dysfunction in all vitiligo cases, Aditi ma'am?
I definitely, I don't go to do thyroid antibodies, but definitely I do TSH. I also do vitamin B12.
B12 also you do.
B12, yes.
Even in kids you do these tests?
Yes, I would give, if I had the opportunity, I would do it.
You would do it. Because sir, screening for thyroid dysfunction, your take on it? Because sir is there. Sir, you are on mute, sir. Yeah.
I do. Am I audible now?
Yes, sir.
Yeah,
Yes.
I do. If it is a very early onset of vitiligo, if there is strong suspicion of other autoimmune conditions, or if there is a strong family history.
Okay.
But frankly speaking, anti-TPO antibodies never help you. They only indicate the autoimmune nature or autoimmune association of a condition, unless there is a very high titer of TPO, which is probably beyond say 300 or 400 or sometimes 500. We hardly have to do any intervention.
Right, right.
So I usually consult and refer them to my endocrine friends if the titer is very high.
Yeah. So treatment
May I intervene?
Yes,
Dr.
sir.
Shreya, please wind up as
Yes,
soon
sir.
as you
Just
can.
5 more minutes, sir. Just 5.
Okay, fine.
Yeah. So topical corticosteroids, calcineurin inhibitors can be given. Oral we can give. So what about apremilast? Can it be tried in these conditions where two autoimmune disorders are coexisting?
Yes. Yes, why not? Apremilast can be tried, but we only should know that steroids are a big no. Other than that, cyclosporine can be tried. Other than that, probably apremilast can be tried, and methotrexate is definitely the to-go molecule. So these are three, and UVB phototherapy localized or excimer for that matter.
Right. Great. A female with high BMI, she's just 6-year-old and has developed rapidly progressing vitiligo. Indrashish, sir, your take on metabolic syndrome with vitiligo?
Yeah, I think there is some association. I think I now actually try to screen for metabolic syndrome in many patients. Actually, it's very easy to do. Actually, so it's one of the easiest things to do. And I think as with any inflammatory condition, we may have an what should I say, incipient or nascent metabolic syndrome kind of stage. So I think in any inflammatory condition, and when you suspect, because obese patients obviously should screen for metabolic syndrome. So I think that's something we can do because it's absolutely routine. You just do fasting blood glucose and lipid profile, and the rest are all clinical examinations. So I think that can be done.
And Shuchibrato sir, what oral immunosuppressant would you use in these cases?
Yeah, it's very difficult. Still in this age, in this child, I'll give, I prefer oral corticosteroid, but very short time. It's very short time. I'll give oral corticosteroid, definitely mini pulse in mode, but there's a very short time. It's only 6 years age actually.
Yes. So yeah, vitiligo does have an association with metabolic syndrome because they share the background of oxidative stress and there is increased pro-inflammatory cytokines. And role of simvastatin has also been explored as an immunomodulator for such patients. And even phototherapy has been found to be, cardio and cerebroprotective in patients with vitiligo. So this was one study that was done and can be looked into. And lastly, coming to female who has been experiencing social withdrawal, she has stopped taking sour food. So Aditi ma'am, do you assess quality of life in all patients in your practice?
No, I wouldn't say assess for all patients in practice, but yes, if people come and say this sort of thing, I try to explain to them what vitiligo actually is.
Right.
And again, it's not contagious. Many of the people, that's very important. And that therapies are available, and not to give up hope, but I don't sit and do a full QOL.
Quality of life, we don't do it. Shomu sir, your take on counseling the patient of vitiligo who has been
Yeah,
experiencing
it's very important because of its social stigma,
yes,
particularly in our country.
right,
And that is basically treating that stigma is as important as treating the patient and their families.
true,
And so in my practice, counseling plays a very huge part.
okay,
And particularly in some particular segments of patient population, like young women, young females, and so on, and also young boys. So the counseling must extend also to the immediate family, including the parents.
yes, of course,
So all these, including the dietary, advice. The dietary advice being mostly that there is no dietary advice
yes,
is very important to stress out.
right, right. Because so newer therapies, any experience with ruxolitinib, it's not available, and there are studies with oral vitlectinib. So any experience or any word on these therapies that are coming into picture now?
No, I don't have any experience.
Any of the panelists would like to share any word on these therapies?
Ruxolitinib, I think it is about to come in India
Okay,
in within a year or so,
okay,
and basically, I mean, it has quite a, as far as the Western experience is concerned, it has a very good kind of reports we have from all around. So I'm hopeful that unless it is priced absolutely beyond the range of our economic capacity, then it should be a good addition to our therapy.
yes.
The
So yeah,
Western protocol is 17,000 per tube of 10 gram. So here we expect it not less than 13,000.
right, so
Completely out of range for any of the patients I treat.
true, that's completely true, and especially when it has to be applied so long term, right? So yeah, the future does look promising for sure. So to conclude, it's an enigmatic disease with profound psychological distress. Important thing is to never trivialize the condition also, which some doctors do. We have to counsel the patients and the parents well. We have to treat actively, keeping in mind the side effects of the drugs, and the future does look promising with Jackinibs on the horizon. So I would like to thank all my panelists for sharing their valuable insights and giving their valuable time, and IDVL West Bengal Academy for giving me this opportunity. Thank you so much.
Yeah. Can I just say one word? We talked a lot about phototherapy, but local phototherapy is also important, and it's practiced quite commonly. So like melanosol lotion diluted in 60% propylene glycol applied for 30 minutes, followed by sun exposure. It generally works very well, and it's cheap, something that is affordable. We didn't discuss that at all.
Exactly.
Thank you, ma'am. Thank you, sir. Thank you, all of you, for joining us. And
Thank
with
you,
this,
Dr.
I have to
Shreya,
do- yes, to the
for
next.
conducting the panel discussion so well.
Thank
And
you,
it
sir.
was really stimulating. Now I'll request Dr. Suchibrata Das to give vote of thanks.
Thank you, Dr. Dinesh for presiding over the total program. We're at the end of the session, definitely a very busy and the schedule of the day. It starts with the observation of vitiligo in every part of our state of West Bengal. We reached 22 medical colleges with our banner and leaflet. We did different types of programs in every colleges, like patient awareness camp, patient counseling. A few colleges, they did some vitiligo surgery. AIMS Kolani, they opened one phototherapy unit today. So it is a great achievement for us actually. And at the end, this excellent information-packed webinar. I'd like to thank Professor Shomesh Gupta sir for his excellent talk on vitiligo surgery, the learning pearls, Dr. Anupam Das, Dr. Avijit Shah, Dr. Sudeep Das. I also like to say thanks to Dr. Shreya Podar's excellent moderation of the session, difficult to manage vitiligo. And the end, I like to thank the members of the person who's active help using the platform, give the opportunity to nicely moderate, circulate the total webinar. And at the end, just I like to thank our office staffs to help us. And with this, just we're ending our session. Thank you. Good night. Thank you to all.